Good morning, dear friends. First of all, I would like to thank Patil sir and Department of Medicine of my alma mater to have me here today. It's really a privilege to be back in your own medical college, and it's always with a different sense of satisfaction you come back to your alma mater. I would like to thank Jan and Hole Madam for their kind words of introduction. And I still remember the PG activities when our faculties, Hole Madam and Chan Madam, would be sitting in front and we'll be doing the PG activity. I mean, those were the days, really the golden days of our lives. So without wasting much time, I am going to talk on anti-diabetic therapy. Dr. Rajkondawar has already talked in detail about the lifestyle modification, which actually is the cornerstone of diabetes. But we all know that it is the most difficult thing to follow for the patients. So we do have a lot of anti-diabetic agents available for treatment of diabetes, as you all know, oral as well as injectable. So let us see where do we stand today and what are the merits and demerits of the various anti-diabetic agents. So when we talk about treatment of diabetes, it is basically the correction of acute metabolic abnormalities, also ensuring the long-term glycemic control to prevent the chronic complications. One needs to have the identification and treatment of the comorbidities before choosing a proper anti-diabetic drug. Now, educating the patient regarding the disease and maintaining high level of motivation is the crux of the treatment, and that is the most difficult thing for us to achieve. Now, the management of type 2 diabetes should not be glucocentric. We all know that diabetes affects each and every part, and especially the cardiometabolic risk or the macrovascular complications of diabetes. And to reduce this cardiac risk, we need to address the hypertension, dyslipidemia, tobacco use, and obesity in patients with diabetes, and these need to be addressed properly in our patients. I think this is the most important slide when we are talking about management of diabetes, and I would like to spend some time here about what is the approach to the glycemic target. And the glycemic target for our patients cannot be fixed for every patient. It cannot be the same. And the factors which we need to consider for treatment, for choosing a proper treatment and the glycemic goals of our patients, how stringent we should be. We know that it is recommended that HbA1c should be maintained below 7 in patients with diabetes. Now, you can achieve a lower HbA1c in certain patients, but in some patients you have to be less stringent and accept a little bit higher HbA1c. So the factors which need to be considered for deciding the glycemic control would be the risk potential associated with hypoglycemia and other drug side effects. So if the risk potential is low to have towards hypoglycemia, you can have lesser HbA1c target. If it is a newly diagnosed diabetic or with a lesser duration of diabetes, one could have a stringent control. On the other hand, if you have a patient who has 15-20 years of diabetes, who is elderly, life expectancy is less, you can have a little bit higher HbA1c target. So less risk of hypoglycemia, shorter duration of diabetes, longer life expectancy means young patient, comorbidities being less, the patient does not have established cardiovascular problems, patient is motivated and has good support system. In that situation, you can target a lower HbA1c in the treatment of diabetes. When you look at the changes in the treatment of patients with diabetes over last 2 decades, since 2000, you would find that it was initially in 2000, it was only glucose lowering agents and glucose lowering modalities for improving HbA1c. Till we came to this point, afterwards, around 2008, it was recognized that HbA1c should be improved without increasing the cardiovascular risk or the risk of hypoglycemia. Again, the cardiovascular and renal outcomes have to be considered for targeting the HbA1c, but now in 2020, we are looking at improved HbA1c and improving the cardiovascular and renal outcomes of the patient. So when we are choosing an anti-diabetic therapy, we have to look at the baseline cardiovascular status and the cardiovascular risk of the patient and the baseline renal status of the patient when we are deciding to choose the anti-diabetic agents, because we have newer anti-diabetic agents which have been shown to increase the cardiac benefits or reduce cardiac problems in diabetes, and also to improve the renal function or renal parameters in diabetes. So if you have a patient who has high cardiovascular risk or high renal risk, you should choose such agents. We all know, you all must have seen this pathophysiological slide of diabetes and how and where these anti-diabetic agents would work. We know that hyperglycemia is caused because of beta cell dysfunction, alpha cell dysfunction, central cause because of appetite regulation being hampered, glucose reabsorption being a problem, insulin sensitivity, lipotoxicity, hepatic glucose output, and the GI tract. So insulin secretion, the beta cell stimulation and insulin we know are sulfonylureas, meglitinides, and incretin-based therapies which would cause beta cell stimulation. Alpha cell suppression is caused by incretins, that is incretin-based therapies, and amylin. Appetite control, central appetite control has been shown again with incretin-based therapies and amylin, and also bromocriptin. SGLT2 inhibitors, which have been there now for last few years, have really changed or added on certain benefits for our patients with diabetes. The insulin sensitivity is improved by thiazolidinediones, metformin, and hepatic glucose output is reduced by metformin and thiazolidinediones. When you look at the benefits of glycemic control, we all know that for 1% drop, there is a significant benefit in terms of cardiovascular complications. The maximum benefits are seen in lower limb amputations and peripheral vascular disease. But overall, if you see, there is more than 30% reduction in the complications related with diabetes by 1% reduction in HbA1c. So targeting the HbA1c is important, but even if you reduce the HbA1c by 1% and prevent the risk of hypoglycemia, you have reduced the significant risk of morbidity in the diabetic patient. I'm sure this is an undergraduate slide where you all have read about what are the various anti-diabetics which are available, the various group of anti-diabetics. We'll briefly go over each one. Biguanides, metformin, we all know is the oldest one. The primary action is on the liver. The exact molecular mechanism is not clear. It activates the cyclic AMP. It inhibits the mitochondrial glycerol 3-phosphate dehydrogenase, which leads to the altered ratio of NAD and NADH. And finally, this translates into decrease in hepatic glucose output. We patients who, in normal physiology also, whatever we eat, the extra glucose is stored in the form of hepatic glycogen. And during the fasting state, especially during the night when we sleep, the liver releases glucose to maintain euglycemia. Now, in patients with diabetes, this hepatic glucose output is more, and you will find that many of these patients who are normoglycemic, when there is a transition from normoglycemia to hyperglycemia, you would find it first thing to happen is increase in the fasting glucose. That's because of increased hepatic glucose output. So the other metabolic effects are the peripheral glucose uptake is increased, that is insulin sensitivity is improved, appetite is reduced, it has an effect on the GLP secretion, weight loss, positive effect on the lipid profile, and also some effect on the blood pressure. Now metformin, it causes glucose lowering by insulin suppression of the endogenous glucose production, that is the hepatic glucose output is reduced, and also the peripheral uptake of glucose is increased. There are certain important uses of metformin, even it's used in pre-diabetes. Dr. Atul Rajkondwar did mention about the Indian diabetes prevention trial where metformin was tried, but it did not prevent the development of diabetes. That's absolutely true. Lifestyle modification is the most important thing, but certain conditions like hyperinsulinemia leading to metabolic syndrome and polycystic ovarian syndrome, that situation, metformin has been shown to improve certain metabolic parameters. The metformin we all know is metformin therapy for prevention of diabetes should be considered in those who are obese, who are elderly, and women who have pre-gestational or gestational diabetes. In them it can be considered. Metformin safety has been shown, but again, lifestyle modification is the primary thing. Now, the dose of metformin is very important. I usually see many times in practice that the patients are started with metformin and they are given suboptimal doses of metformin. The recommended dose of metformin is anywhere the optimum dose of metformin is 1500 to 2500 milligrams per day, and the maximum dose of metformin is 3000 milligrams per day. You find that many times the patient is started just on 250 milligrams of metformin once a day or twice a day. It really doesn't make any difference in terms of glycemic control. But yes, if GI side effects are more, which are dose dependent, in that situation you can start with lesser dose of metformin and gradually build it up to a therapeutic dose, which is 1500 to 2500 milligrams of metformin daily. Another concern of metformin use is in CKD. And till now we were all following the fact that if the creatinine goes beyond, there have been, if you read the older papers, it would say creatinine more than 1.8 in men and 1.5 in women, one should not give metformin. Then came the concept of eGFR. Now eGFR, if it is less than 45, one should not give metformin. Otherwise the risk of metabolic acidosis increases. But now it's been shown that risk of metabolic acidosis frankly is very low. Lactic acidosis. I mean, frankly speaking, in my 25 years of endocrine practice, I have not seen lactic acidosis. There was one case of lactic acidosis presented in one of the Academy of Medical Sciences clinical meeting in Nagpur, which I have heard. So, lactic acidosis is a documented fact, but it is very rare. Metformin can be used in patients with CKDs and even below the eGFR of 45, but below eGFR of 30, definitely it should not be given in patients with CKD. Now, the cardiovascular benefits of metformin have been shown in the UK PDS trial, and there are certain COVID benefits of metformin which have been looked at, but again, these are all things which really need to be looked at more critically. The mechanism of metformin potentially associated with the micro and macrovascular protection in terms of reduction of adiposity, decreasing the insulin resistance, fibrinolysis is increased, the plaque deposition, the fat deposition in the plaques is reduced, oxidative stress is reduced, and these are the mechanisms because of which metformin causes protection against macro and microvascular complications. The second group of drugs and the commonly used drugs are the sulfonylureas. Now, with the advent of newer drugs, let me tell you one thing, there has been a lot of campaign against sulfonylureas by a good number of pharma who are bringing in newer drugs, but sulfonylureas have stood the test of time. They still are the ones which are commonly used. These are the ones which were discovered long back, more than 6 decades ago, and the older sulfonylureas like tolbutamide, chlorpropamide are not available and used now. We do have available glibenclamide, glipizide, glimepiride and glyclazide, and these are the main actions we know that they stimulate the beta cells of pancreas, to some effect have an effect on the alpha cells, but predominant action is on the beta cells, and some of the sulfonylureas like glimepiride would have a reduction in hepatic glucose output to some extent, not much. And this, I'm sure you all know the pathophysiological, or rather the mechanism of action of sulfonylureas when they act on the sulfonylurea receptor, causing depolarization of the cell, calcium influx, and release of insulin from the beta cells into the circulation. Now, this is how the journey of sulfonylureas has progressed over time since 1942. And initially, there was a concern about cardiovascular risk of sulfonylureas, which was reported in the UGDP study long back in 1970, where it was tolbutamide which was reported to increase the cardiovascular risk. But with the better profile of sulfonylureas available, and now we do have glyclazide, which has been shown to be beneficial in, it's not beneficial, but it has been shown to be safe, cardiovascular-wise safe in patients with diabetes. And similarly, patients on glimepiride have been shown to have no increased cardiovascular risks with the sulfonylurea glimepiride. When you look at these 4 sulfonylureas which are available, these are the half-lives, which are duration of action, which is available, and the daily recommended dose. One thing I want to stress here is when a patient is on glibenclamide, you see that the half-life and duration of action is more. So when a patient on glibenclamide presents with hypoglycemia, you need to monitor the patient closely for not just for a short period of time, but at least for 24 to 48 hours. And especially if the patient has got renal insufficiency, the half-life of glibenclamide will be further increased, and one needs to be careful when the patient has got hypoglycemia secondary to glibenclamide. We all know the hypoglycemic potential of sulfonylureas. They would reduce the HbA1c to anywhere between 1 to 1.5%, and in combination, they would reduce the HbA1c somewhere around 1.5 to 2%. Now, the modern sulfonylurea glimepiride and also glyclazide, they abolish the sulfonylurea other than glimepiride and glyclazide. They abolish the ischemic preconditioning, but glimepiride and glyclazide do not have this effect. Now, these modern sulfonylureas have been shown to be safe in patients with cardiovascular or cardiac problems. However, in patients who have heart failure, those who have unstable CAD, those who have arrhythmias in them, one should use them in caution, because hypoglycemia itself can trigger some of these like arrhythmias and all. But otherwise, these newer sulfonylureas are safe in cardiac patients. Now, they have stood the test of time and they have been recommended as second line. We'll come to the guidelines of recommendation. The ADA does recommend sulfonylureas, and I think this is where it's most commonly used in our country, in India. When you look at the recommendation, it does mention that after when the patient is on metformin and lifestyle, you assess the cardiovascular risk. Now, if the cardiovascular risk is not high, then you look at various factors: compelling need for hypoglycemia, compelling need for minimizing the weight, and the cost issue. In our country, cost is a significant factor, so I think we have to be conscious enough, and majority of our patients are self-pay patients. So in that situation, I personally feel we should not jump at these newer anti-diabetic agents always. Newer anti-diabetic agents are good. The DPP-4 inhibitors, the SGLT2 inhibitors, they are good. They cause less risk of hypoglycemia, but one should also look at the patient's pocket. If you forget that, you will find that the patient's compliance with the treatment is very low. It's very important. So in patients who had established cardiovascular disease, the sulfonylureas are much below in the recommendation, and so also the case where it's hypoglycemia is a consideration. Similarly, AACE, the American Association of Clinical Endocrinologists and American College of Endocrinology, they also do recommend you could use sulfonylurea, and the use of sulfonylurea is based, again, on whether the baseline HbA1c, the entry-level HbA1c is between 7 to 9. You could start with dual therapy with metformin, or with triple therapy with metformin, again considering all other factors. Now, non-sulfonylurea secretagogues like ripaglenide and nitaglenide are also available. Now, these two are also secretagogues. They also act at sulfonylurea receptor, or the subunit of sulfonylurea receptor. It is a 55 kilodalton subunit of sulfonylurea receptor on which, and the typical action of these, or the importance of this is, these two act on this 55 kilodalton receptor. They attach and detach quite faster. As a result, their action is fast, and since they dissociate fast from the receptor, the risk of hypoglycemia is reduced, and that's the reason why drugs like ripaglenide and nitaglenide will be used postprandial hyperglycemia. So when you have a patient whose profile, when the patient is monitoring blood sugars and you find that the postprandial glucose are high, one of the options for use would be ripaglenide or nitaglenide. Now, the other newer group of drugs are the SGLT2 inhibitors, which are now available and are affordable now. So when you look at the SGLT2, when you look at the normal glucose handling by the kidney, we know that a good amount of glucose is filtered from the glomerulus. It enters the proximal tubule, but 90% of this glucose is reabsorbed in the proximal tubule by the SGLT2 receptors. And remaining 10% is absorbed by the distally placed SGLT1 receptor. So essentially, there is no glucose or very minimal glucose in the urine. Now, these newer group of drugs, the SGLT2 inhibitors, will block this receptor right here in the proximal convoluted tubule, because of which the reabsorption of glucose is reduced and there is glucosuria. More amount of glucose is excreted in the urine, and that would cause reduction in the blood glucose. Now, this mechanism of action I did mention to you, and they would cause the decrease in the blood pressure, arterial stiffness. They also have an effect on the lipids. They would cause some amount of volume loss also. Weight loss has been noted in patients with SGLT2 receptors. SGLT2 receptors have been shown to have effect on the adipose tissue distribution also. SGLT2 inhibitors have been shown to reduce the central fat. There have been studies where SGLT2 receptors have been looked at in terms of reduction of epicardial fat. So apart from glycemic reduction and glycemic benefits, they have other metabolic benefits also. So the benefits, the glycemic benefits of SGLT2 inhibitors are insulin independent. As I mentioned to you, they do not work on the beta cells, they work on the proximal convoluted tubule. They do have a reduction in A1C both, and there is no risk of hypoglycemia because it's not related, it's insulin independent. They would cause the effects, as I mentioned, weight reduction, blood pressure control, lipid benefits, cardiovascular benefits have been shown, which we would look at, and also the renal protection. These are the various trials of SGLT2 inhibitors which have been done and completed. These are landmark trials which have been done with empagliflozin, canagliflozin, dapagliflozin, ertugliflozin, and all these trials have shown that there is a clinical benefit in terms of cardiovascular risk as well as renal risk in patients who were treated with SGLT2 inhibitors. Now, this is the DECLARE-TIMI trial where dapagliflozin and cardiovascular outcomes in type 2 diabetes were looked at. More than 17,000 patients randomized 1:1 to dapagliflozin or placebo, and the primary endpoints were major adverse cardiac events. If you look at the study results, it was shown that patients who were in the dapagliflozin group, in them the cardiovascular risks and hospitalization due to heart failure were significantly less. Similarly, major adverse cardiac events were significantly less, and these definitely were statistically significant. secondary endpoints which were looked at were the renal composite endpoints in terms of reduction in eGFR, progression to end-stage renal disease and vascular deaths, and all-cause mortality. The all-cause mortality was not much different, but these renal composite endpoints were significantly better in the group which was treated with dapagliflozin. Again, this DAPA-HF trial, looking at the dapagliflozin in patients with heart failure with reduced ejection fraction. Again, in this, those patients who were treated with dapagliflozin had decreased incidence of heart failure. Now, this DAPA-HF trial was important or remarkable in one aspect, that even in non-diabetics, when these patients were given dapagliflozin, these were normoglycemic patients. In them also the benefit of dapagliflozin was seen as compared to placebo in terms of heart failure and cardiovascular deaths. And that's the reason why now you would see majority of our cardiovascular friends or cardiologists who would be using dapagliflozin even in non-diabetic patients. So this effect of dapagliflozin on worsening heart failure and cardiovascular death was seen in various subgroups of patients irrespective of their diabetes status, renal status, whether their background therapy, the diuretic therapy or LVEF at baseline. In all these patients, there is a beneficial effect of dapagliflozin. Another landmark study of dapagliflozin is the DAPA-CKD trial, where again these patients were looked at in terms of renal benefits, and it was clearly shown that those patients who were treated with dapagliflozin had much lesser progression of renal events as compared to the patients who were treated in the placebo group. Now, you would find there is a consistent reduction in the HbA1c across a broad range of commonly prescribed treatment when patients with this dapagliflozin group, whether they were on metformin, sulfonylurea or other OH. When you look at the ADA recommendations for SGLT2 inhibitors, SGLT2 inhibitors have really changed the treatment and recommendations in terms of the cardiovascular patients. So after metformin and lifestyle, if there are significant cardiovascular risk factors and established cardiovascular disease, independent of HbA1c, the SGLT2 receptors are significantly important in treatment of these patients. So European Society of Cardiology also does recommend that patients who are diabetics and drug naive, who have atherosclerotic cardiovascular disease or who are at high risk, in them SGLT2 inhibitor should be given. If they do not have risk of cardiovascular disease or they do not have atherosclerotic cardiovascular disease, then monotherapy can be continued. But if they have any risk, SGLT2 inhibitors can be added irrespective of their glycemic control. The next group of drugs is thiazolidinediones, the pioglitazone, rosiglitazone. We all know rosiglitazone is no longer available. Pioglitazone is available, which works on the nuclear receptor PPAR gamma, which causes translocation of the GLUT4 protein and thus helps in transportation of glucose into the cell and causes reduction in the insulin resistance or insulin sensitivity. The beneficial effects of thiazolidinediones are improvement of insulin sensitivity. They have an effect on the positive effect on the adipose tissue distribution, beneficial effect on dyslipidemia in terms of increase in HDL level, plasma triglycerides are reduced to some extent. The glycemic control is seen both fasting as well as postprandial, and the risk of hypoglycemia is low because it does not have an effect as monotherapy. It has also been shown to have decrease in the liver steatosis and to some extent beta cell preservation. Another important group of drugs we all have last maybe decade or two are the incretin mimetic drugs. DPP-4 inhibitors and GLP-1 receptor agonists. You all know the incretin effect, and we know that once we have ingested the food, the GI tract secretes the incretins GLP and GIP, which then go from the GI tract to the pancreas, stimulate the beta cells to make insulin and suppress the alpha cells to suppress glucagon. Now, DPP-4 inhibitors are the drugs which we know that these GLP-1 and GIP, the incretins which are made in the intestine, they are inactivated within minutes to inactive GLP and GIP by the enzyme dipeptyl peptidase 4. And the DPP-4 inhibitors are the drugs which inhibit this enzyme, and by inhibiting this enzyme, the levels of endogenous GLP and GIP are increased, which then have an effect on the beta cells and alpha cells. So these are the incretin mimetic effects which are seen on in terms of their effect on the brain satiety center, in terms of gastric emptying on the GI tract, on glycogen synthesis is enhanced. They have an effect, stimulatory effect on insulin and inhibitory effect on glucagon. Effect on lipogenesis is doubtful. Now, DPP-4 inhibitors, they have caused significant paradigm shift in the management of diabetes in last decade or so. There are these various DPP-4 inhibitors are available, sitagliptin being the first DPP-4 inhibitor which was available, after which we have linagliptin, saxagliptin, teneligliptin, vildagliptin, and now we have these gliptins which are at affordable price, vildagliptin and teneligliptin, which are available. Now, if you look at the DPP-4 inhibition, you need at least 80% inhibition in good number of for significant duration of time for it to be working having significant glycemic effect. Find that these inhibitors, the inhibition of DPP-4 is variable, and that's the reason why the dosages are also variable. Another important thing is glycemic variability, which is not my topic today, but I'm sure you must be aware of glycemic variability and the concept of good and bad HbA1c. You can have the same HbA1c, a patient can have an HbA1c of, say, suppose 7.5, and his blood sugars would be fluctuating less around a baseline and having an HbA1c of 7.5. In contrast, there could be another patient who would have an HbA1c of 7.5, but having wider fluctuations in blood sugars, hypos and hypers, and HbA1c remains 7.5. The first patient's HbA1c is better, and second HbA1c is not a good HbA1c. And that's the reason why the concept of glycemic variability has come, and it has been shown that irrespective of HbA1c, the complications do depend on glycemic variability. So now, as clinicians, we should also be looking at therapies which would reduce glycemic variability in our patients. And DPP-4 inhibitors are one of those drugs which do reduce glycemic variability. And it's been shown that glycemic variability leads to various micro and macrovascular complications, more so in microvascular complications, as is shown here in this slide. Neuropathy is increased. Here it mentions nephropathy, but it's neuropathy. The neuropathy is more severe when the glycemic variability is more. When the glycemic variability is less, the neuropathic symptoms are less. The other incretin mimetic therapy is the GLP-1 receptor agonist. These are again, they have a glucose-dependent mode of action, lower risk of hypoglycemia when used as monotherapy or along with insulin sensitizers. The GLP-1 receptor agonists have significant effect on weight. They do cause weight loss. There is favorable cardiovascular profile which is noted, and they are approved by ADA and ESD as second line after metformin, especially in CVD along with SGLT2 inhibitors. So these two group of drugs, SGLT2 inhibitors and GLP-1 receptor agonists, are the ones which have really climbed up the ladder in recommendation, especially in patients who have cardiovascular risk. And now if you ask me, the DPP-4 inhibitors also have increase in GLP and GIP, same as GLP-1 agonist receptor agonist. Then why do they don't have the cardiovascular benefits? They have similar effect, right? By blocking the enzyme DPP-4 inhibition, they will increase the endogenous level of GLP and GIP. Anyone? The DPP-4 inhibitor studies, in terms of cardiovascular outcome studies like the TACO study or Carmelina, shown that these DPP-4 inhibitors do not have cardiovascular risk. They are cardiovascular neutral, but they do not have cardiovascular. While GLP-1 receptor agonist studies have shown that they have cardiovascular benefits. And that is because by DPP-4 inhibition, you increase the endogenous GLP or GIP by only 4 to 5 times. While giving GLP-1 receptor agonist, the amount of GLP which is increased is many folds, maybe 50 to 100 folds, and that has been shown to have significant benefits in terms of cardiovascular effects. Now, these various studies in terms of this meta-analysis of cardiovascular mortality and mortality and non-fatal strokes with various GLP-1 receptor agonists, these cardiovascular benefits are definitely there in these group of drugs, the GLP-1 receptor agonists. And now, in this month of January 2022, we are going to get semaglutide oral form. Till now, all the GLP-1 receptor agonists were available in injectable form. Now, semaglutide will be available in this month as oral tablet, which has been shown to have similar benefits and similar effects as compared to injectable semaglutide. The other group of drugs is alpha-glucosidase inhibitors. We all know that these group of drugs block the alpha-glucosidase at the brush border of the intestine, and they do not inhibit the absorption of glucose, but they delay the absorption of glucose. They do not block it completely, but by slowing down the degradation of complex carbohydrates to simple carbohydrates, they would reduce or slow down the absorption of glucose from the GI tract. And one very important question which we always would be asking in endocrine exams to the students is, if a patient with if a patient with alpha-glucosidase inhibitor develops hypoglycemia, what instructions should you be giving to this patient? See, the commonest thing which people do is, ghar mein 2 chammach shakkar kha li, or having something sweet at home they will eat. But here you are giving alpha-glucosidase inhibitor, which prevents the digestion of complex carbohydrates to simple sugars. So by having something sweet is not going to help them. In that situation, they should be given free glucose. That's one instruction which we give to our patients when we prescribe them alpha-glucosidase inhibitors. These are most useful in patients who consume diet rich in complex and digestible carbohydrates, and that's precisely the reason why these group of drugs, alpha-glucosidase inhibitors, are the drugs which are commonly used in India, but in Western countries, alpha-glucosidase inhibitors are not used because their diet is predominantly protein diet. But ours is predominantly a carbohydrate-based diet, and in our situation, in Indian situation, one could use or one should use alpha-glucosidase inhibitors for glycemic control. You could use voglibose, you could use acarbose, you could use miglitol. Now, this recommendation of the Association of Physicians of India, it does mention that alpha-glucosidase inhibitors have a crucial role in Indian type 2 diabetes because of the high carbohydrate diet. They are effective in lowering the postprandial glucose, and they can be used as first-line drugs in early diabetes as well as in combination with metformin or with insulin. The other drugs which are there, bromocriptine, frankly speaking, I haven't used bromocriptine much, but yes, bromocriptine has been shown to have an effect centrally and to cause satiety in patients. Now, the last few slides I'll be talking about insulin. Now, when to start insulin in patients with type 2 diabetes? We know type 1 diabetes definitely, but in type 2 diabetes, indications. One, patient fails to achieve the glycemic targets on current OAD. Now, this is a very ambiguous term. I would like to clarify here. It's not just current OADs. It is on optimum doses of OADs. Please do not go to the maximum dose. You would find that many patients and many clinicians would go to the maximum, try to go to like 4 doses, 5 drugs to the maximum dose of oral drug till the time you start insulin. But that causes delay in insulinization, and the longer the patient remains hyperglycemic, the risk of macro and macrovascular complication is there. And this inertia for starting insulin should be avoided. So if you find that the patient is not well controlled with optimum doses of oral agents, one should consider insulin therapy. Suppose the patient needs flexible therapy, that should be looked at. Patient cannot tolerate oral agents and one should follow the guidelines. Other patient profiles, when adequate glycemic control is not obtained, and in patients with myocardial infarction, stroke, hepatic renal insufficiency, patient going in for major surgery, pregnancy, lactation, all these situations, insulin should be considered. Now, we do know that insulins are available as human insulins and insulin analogs. Insulin analogs we know are available as short-acting as well as long-acting insulin analogs. Short-acting insulin analogs are used as bolus insulins, predominantly for postprandial glycemic control. One should use, or rather can use, premix insulin for convenience sake. But I personally prefer to titrate the dose of short and long-acting insulin first and then decide to put the patient on premix, whether to put on premix 50-50 or to put on premix 30-70. Starting with premix right in the beginning causes hypoglycemia in good number of patients. Now, another way of treating the patients with diabetes would be what was earlier called as BITS therapy. Bedtime insulin, daytime sulfonylurea. Sulfonylurea means oral agent. So in patients who are not well controlled on oral agent, you can start them with a basal insulin at night, once a day, any of these long-acting insulins, preferably glargine, detamir or degludec. NPH can, the risk of hypoglycemia is more, but again, when finances are considered, NPH can also be used. And one can use basal insulin, along with that oral agents can be used. These, I think I won't go into the details, this I'm sure you all are aware. Now, when we talk about giving insulin to our patients, we should match the insulin profile with the patient's glycemic profile. That is very important. When you choose an insulin for the patient, you consider the insulin profile first and then the patient's glycemic profile. If you find that the patient's fasting sugar is more or the pre-meal blood sugar is more, you may add or increase the basal insulin. If the patient's postprandial sugars are higher, increase the bolus or short-acting insulin. Premix insulin, again, as I mentioned, if you find that the patient is controlled on a fixed dose like 30-70 or 50-50 of short and intermediate, then you can. And if both the pre-meal as well as or fasting as well as postprandial sugars are elevated, you can elevate or increase this dose. And this is split mix where you can give the patient separate doses of short-acting as well as long-acting, and there are certain co-formulations of short-acting insulin analog and basal insulin analogs which are available, but one should choose them based on the patient's glycemic excursions. Now, the basal insulin recommendations, I think these are more theoretical things, but you, I'm sure, must have gone through depending on the HbA1c. If the HbA1c is below 8 and patient needs insulin, one could start with 0.1 to 0.2 units per kg. If HbA1c is more than 8, start with a higher dose. Gradually up-titrate the dose based on the patient's blood sugars being checked every few days. Now, to summarize at the end, we have all these drugs which are available: metformin, SGLT2 inhibitors, GLP-1 receptor agonists, but we should choose these drugs based on what we want for our patients. And as I mentioned to you, the first slide, the important one, where you should achieve more tighter control and patients who are elderly having comorbid conditions. So you should be choosing the drugs based on the clinical condition of the patient. If the patient is high risk for cardiovascular disease or has established cardiovascular disease, after metformin, one should choose SGLT2 inhibitors or GLP-1 receptor agonists which are available. DPP-4 inhibitors, which I told you, are the ones which do cause less risk of hypoglycemia. Again, they are the designer drugs. Risk of hypoglycemia is less. Thiazolidinediene, sulfonylureas, we already discussed. They are there to stay, the second generation ones. They are efficacious. They have a risk of hypoglycemia. They do cause weight gain. But then when glycemic control is there important, they have a high efficiency, and we should consider judicious use of sulfonylureas. Now, these are the recommendations or guidelines for anti-diabetic treatment as of 2022 given by ADA, which we did discuss earlier also. The first line would be lifestyle modification along with metformin. Then, after that, look at your patient's cardiovascular risk. If the patient has got established cardiovascular disease or high risk for cardiovascular disease or CKD or heart failure, then one should look at whether it is atherosclerotic heart disease, CKD or heart failure. If it is a patient having heart failure, one would consider SGLT2 inhibitors first. If it is atherosclerotic heart disease, established or high risk, one could use GLP-1 receptor agonist or SGLT2 inhibitors. And in patients with established CKD, one could use the SGLT2 inhibitors. When there is no established cardiovascular disease or risk is low, in that situation, one should choose the second drug after metformin based on whether you want to add the drug for glycemic control, weight control, and also look at the patient's pocket. And then you should choose the drug. Again, this injectable therapy we already discussed. Now, RSSDI guidelines also are on similar lines, and RSSDI guidelines also do mention that you consider the patient's age, A, B, C, D till H. A is for advancing age, B is for increasing BMI, C is for CKD, D is for duration of diabetes, E is for established cardiovascular disease, glycemic status, hypoglycemia. Now, if the patient's age having advancing age, one could choose these drugs. If the BMI is more, the primary consideration is weight loss, then in that situation, SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4, alpha-glucosidase inhibitors would be the one, and then at the end would come sulfonylureas. In patients with CKD, you would choose SGLT2 inhibitors as the first. After that, DPP-4 inhibitors. In long-standing diabetes, again these. So this is a very good recommendation which should be followed in patients when we are thinking and modifications. So one needs to individualize the diabetes treatment based on all these factors, and the ABCDEFH approach which I discussed with you should be followed, and that would help side effects and achieve better glycemic control. So dear friends, what I would like to suggest here is, when you look at diabetes drugs or therapy for our patients with diabetes, individualize the therapy and also individualize the glycemic targets. It's an elderly patient who has comorbidities, you can be a little bit relaxed in terms of his glycemic control to prevent hypoglycemia in this patient. Do not aim aggressive control in elderly people and also in very young people. Use of insulin has to be properly decided based on this patient's side effects of anti-diabetic drug. Look at when you are considering using the drug. One should have proper cardiovascular risk assessment in patients with diabetes, with type 2 diabetes, when they are choosing anti-diabetic therapy for that. Aim at tight glycemic control from the beginning, because it's been very clearly shown, you all know the legacy effect. The UK PDS has very clearly shown that when the diabetes, at the beginning of diabetes, when you control the sugars better and you have a good glycemic memory, the risk of long-term complications of diabetes is significantly reduced. So that all these factors have to be considered. Thank you very much. I would be happy to answer any questions.